My name is Mark Newman from the University of Pennsylvania Perelman School of Medicine in Philadelphia, and I'm excited to speak with you today about health services research in anesthesiology. What is health services research? Health services research examines how people get access to health care, how much care costs, and what happens to patients as a result of this care. The main goals of health services research are to identify the most effective ways to organize, manage, finance, and deliver high-quality care, reduce medical errors, and improve patient safety. And this quote comes from the Agency for Healthcare Research and Quality, which was published in 2002. Well, anesthesiology and surgery have actually been part of health services research from the very beginning. The National Halothane Study was a landmark study conducted at 34 hospitals in the United States to understand the potential risks of a then new anesthetic agent, which was halothane. Well, one finding from the study, which was an incidental observation, was that there were major institutional differences in postoperative death rates across the hospitals that participated in this project. And they ranged from 0.27% to 6.4%, a 24-fold ratio. These were reported in an article in JAMA in 1968 by Lincoln Moses and Frederick Mosteller, two of the statisticians involved in the National Halothane Study. Well, Moses and Mosteller were able to show that a substantial amount of this variability related to differences in the health of the patients treated at hospitals in the study and the case mix, the type of surgeries that they did at these institutions. But at the same time, there was a substantial amount of variability they couldn't explain through these factors, leading them to raise questions about whether there might have been quality differences across these hospitals or differences in patient safety or how patients were selected for surgery. This is one of the very first observations that noticed variability in important outcomes for medical conditions overall, but surgery in particular across US hospitals, and really started a process of looking more deeply into that through health services research that has continued to today. The medical practice of anesthesiology and perioperative medicine really spans a huge number of clinical domains, including operative anesthesia services, obstetric anesthesia services, critical care, pain management, and other areas. And health services research in the field touches on all of these. Topics that health services research in anesthesiology can address include questions of access, whether there are limitations to access to needed or basic specialized anesthesia services, and whether or not specific populations might be at risk of having inadequate access to such services. Questions of cost, such as how do anesthesia services impact costs of care to society and to individuals, and what the relative cost might be of different models or approaches to care. In terms of quality and outcomes, we can ask how we define the quality of anesthesia care and how quality might differ across providers and institutions, and for what reasons. Important questions also include whether the quality of anesthesia care differs across patient populations and why that might be, and whether specific approaches to delivering care might be able to reduce variability in quality and outcomes across providers, institutions, or populations. Health services research takes advantage of perspectives from a wide range of disciplines to address these questions. These can include health economics, clinical epidemiology, biostatistics, medical sociology, bioethics, decision science, and human factors engineering, among others. And health services researchers use a range of approaches to address these questions, including retrospective analyses of administrative databases and registries, qualitative studies in clinical settings, provider and patient surveys, and prospective interventional studies, including cluster or patient-level randomized controlled trials. I'd like to share with you a few examples of perioperative health services research that illustrate the breadth in terms of topics, as well as the variety of methods that come to be used in this area. This work by Catherine Chen and her colleagues at UCSF was funded through a FAIR Research Fellowship grant. Catherine became interested in studying utilization of preoperative medical testing in patients undergoing cataract surgery. Guidelines at the time and presently still recommend against routine preoperative medical testing for cataract surgery patients who don't have other major medical problems. These types of tests are unlikely to impact outcomes and may increase costs, as well as potentially putting burdens on patients. Studying 440,000 patients using Medicare claims data, Catherine and her team observed that more than half of patients undergoing cataract surgery had preoperative medical testing in the month prior to surgery, and that costs of care spiked for these individuals in that month compared to the 11 months prior. Over a third of ophthalmologists ordered preoperative tests for more than 75% of their patients, with a high degree of variability in testing use across ophthalmologists. As an example of where this work can lead, I'll show you a subsequent study by Catherine Sarkisian and her team at UCLA. Building on the work that Catherine Chen published earlier in the New England Journal of Medicine, Catherine Sarkisian and her team developed a multi-component intervention focused on behavior change among anesthesiologists and ophthalmologists to decrease potentially low-value care in the preoperative period for patients undergoing cataract surgery. What they demonstrated is that through this multi-component intervention, they were able to decrease preoperative medical visits and preoperative testing, including chest x-rays, laboratory testing, and preoperative electrocardiograms. And for the testing measures, chest x-rays, laboratory tests, and electrocardiograms, these changes were sustained even beyond the specific intervention period itself. All in all, this team estimated a greater than $200,000 savings from the societal perspective for decreases in testing associated with their interventions. In our own group, we've examined the relationship between anesthesia provider training and patterns of care for cesarean delivery. Current recommendations for obstetric anesthesia include guidance for patients to be offered spinal anesthesia or regional anesthesia as an option for care for cesarean delivery. Some experts have recommended avoidance of general anesthesia where patients don't have contraindications to regional anesthetics for considerations of patient experience and potentially also safety. In our institution, we examined how care patterns differed among providers who'd received additional training to specialize in obstetric anesthesia versus generalist providers who were providing care for cesarean delivery. And we observed that the use of general anesthesia was higher among generalist anesthesiologists compared to obstetric specialized providers. Additional work that could follow on from this could be qualitative research to understand the reasons for these differences, as well as interventional studies focused on changing patterns of practice. Finally, I'll come back to the basic observations that we saw from Moses and Mosteller in 1968, just to illustrate that this story has continued to play out in the 5 decades since then. In the early 1990s, my own mentor, Jeff Silber at the University of Pennsylvania, became interested in understanding the relationships between complications and mortality and looking more closely at how these relationships might help us to understand some of the types of variability that Moses and Mosteller first pointed out in 1968. This work continued on and fed into other research. In 2009, Amir Ghaffari, John Berkmeyer, and Justin Dimmick built on what Jeff Silber had done by looking at the relationships between complications and mortality across different hospitals. One thing they ended up finding was that while complications seemed to occur at similar rates across hospitals with differing mortality, the rate of death after a major complication varied markedly. Hospitals with high mortality had a very high likelihood of death after a complication compared to hospitals with low mortality, potentially arguing that while complications may occur in similar ways across hospitals, the response to complications may be what distinguishes institutions with high versus low mortality. And this work continues on even beyond and into today. Health services research is a growing field in anesthesiology, and there are lots of great early career investigators who are working in this space. This slide highlights 5 recent FAIR grantees whose work touches on different aspects of health services research in different ways, looking at patient safety, quality, and provider training. And finally, I'd like to highlight a few different opportunities for those who are interested in getting started and learning more. There are training opportunities through FAIR, not just limited to the MSARF program, but also to the Mentored Research Training Grant Program and the Research Fellowship Grant programs that are available to individuals in their fellowships and beyond. The National Clinician Scholars Program is a training program for individuals who have completed residencies to provide additional time and training to learn how to become independent investigators in health services research. The NIH offers additional training opportunities through the T32 programs, and this link will take you to a listing on NIH Reporter of all the T32 programs currently housed in anesthesia departments across the US. Health services research work is featured at society meetings within anesthesiology. ASA, IARS, and APSF all feature health services research work to differing degrees. Outside of anesthesiology, Academy Health is a national organization that focuses specifically on health services research and is a great venue to learn about the field and get connected. Finally, there are a variety of journals and other resources where one can learn and read more about health services research. Within our field, these include anesthesiology, anesthesia and analgesia, and other publications. Health services research journals more generally include HSR, which is called Health Services Research, Medical Care, Milbank Quarterly, and Health Affairs, and then general interest journals such as JAMA, New England Journal, and Annals of Internal Medicine frequently publish health services research work that has implications for policy more broadly. I look forward to taking your questions, chatting with you more about my own experiences in health services research, and providing more information in the discussion. Thank you very much and take care.